One of the interesting things about the Achilles tendon is that researchers have found a significant correlation between tendon pain and a thickening of the paratendon, that sheath around the tendon. This additional thickness may contribute to the pain of the condition, and in chronic tendinopathy conditions of the Achilles, this thickening is often palpable. It's been known for years that the Achilles tendon has a spiral twist of approximately 90 degrees from its origin down to its calcaneal insertion. Theoretically, researchers are hypothesizing that the twisting most likely helps provide functional resistance to load stretches on the tendon, but it may also affect the biomechanical properties of the tendon by generating an area that's prone to injury, which is approximately 2 to 3 inches, that's 5 to 7 centimeters for the metric people, proximal to the insertion. And so that's usually considered to be mid-portion tendinopathy. So it's interesting that this twist, which we've known about for years, which is supposed to be for stability and strength, is also the area where the injury most often occurs in the Achilles. So as these Achilles tendon fibers travel distally from the gastrocnemius and the soleus toward the insertion, the individual subtendons twist around each other. The direction of the twist changes based on whether it's the right ankle or the left ankle. The left Achilles twists clockwise from origin to insertion, and the right Achilles twists counterclockwise. For Achilles tendinopathy, we're doing a special orthopedic test that stresses the tendon by having the client do a calf raise, which strongly contracts the calf muscles. We'll have her hold it at the top for a few seconds, and then repeat that a couple of times to see if that elicits the pain they're complaining of. If the double calf raise is a negative, if there's no increase in pain, then we'll have Sammy just do a calf raise on the affected side to see if that generates or elicits the pain she's complaining of. So, Sammy, I'm going to have you start by doing a double calf raise and then hold it for a couple seconds at the top and back down, and do that one more time and come back down. And since that is not painful for her, we're going to have her right Achilles is the affected one in our example here. So you're going to do a calf raise just on the right. You can bend your left knee and then up again and back down. And either the client will say that's painful or it's not painful. And even though this test may end up being negative, as I said earlier in our class, the results of one test do not make or break your whole assessment process. It's just information gathering at this point until you can determine what needs to be treated. In doing assessment for the Achilles, another way to challenge the tissue is with the client in a prone position and have them completely dorsiflex, and then we'll provide a strong isometric contraction. So start slowly and press against my hand. I'm just stabilizing her here, trying not to have her move. Just trying to load the tendon. Hold it like that. Hold it, and relax. And that's going to either be a positive test, which would be eliciting the pain she's complaining of, or a negative test. So that's just a different version from the test that we did in the standing position. During the assessment process, observing the Achilles tendon means just having a look to compare the uninjured side to the injured side. And the reason we want to do that is because many times people with Achilles tendinopathy have chronic issues. They've injured it more than once, and it's never really been healed or rehabilitated completely. And so sometimes the affected side will be thickened. There might be swelling along the edges of the tendon. You might notice redness. You may also be able to notice and palpate nodules on the tendon where the injury has occurred over and over. So Sammy's had a few injuries to her Achilles in her athletic career. We're just going to have a look and see what we see as part of our assessment for her. So looking at her right side, The tendon is pretty visible. She doesn't really have any significant swelling here, no nodules on the tendon. On her left side, the tendon appears to be a little bit thickened, and there might be a little bit of edema here. It's not significantly different than her right side. As I said earlier about Achilles tendinopathy, it's an overuse injury, usually develops over the course of several months. Many people who have Achilles issues have chronic Achilles issues that will calm down and then flare up and then calm down and flare up. And just as a reminder, Achilles issues generally end up being in the mid portion of the tendon. So if you think about the tendon attaching to the calcaneus, and here's the round part of the tendon, here's the musculotendinous junction. The most typical presentation is somewhere in the mid portion, or it's also called insertional Achilles tendinopathy if it's pain at the insertion on the calcaneus. And because the Achilles tendon transitions into the plantar fascia on the bottom of the foot, many times people with Achilles issues also have plantar fasciitis type of pain in the bottom of the foot. In the early stages of Achilles tendinopathy, as in many overuse injuries, the pain may begin at the beginning of, say, a run, and after the athlete is warmed up a bit, it goes away. As it gets worse, the pain may return after the cool down, and then as the athlete continues to train, the condition will worsen over time so that it takes longer during the warm-up for the pain to go away. The pain comes back sooner after the cool down, till eventually the symptoms are there all the time. If we can find and treat the Achilles tendinopathy early, that's going to be better than waiting until a client comes in already complaining of pain in the tendon. When you do some gentle palpation of the tendon, because this is a sheathed tendon, we want to have it on a little bit of a stretch, and we're just palpating for the most tender spot. And this is still part of the assessment process. Many times there'll be a nodule or a thickening of the tendon. And as you compare it to the tendon on the uninjured side, you may notice some general thickening around the tendon. There could be some long-term swelling or edema that it develops over the course of the length of the injury. So I've had Sammy slide down to the end of the table so her feet hang off, because I want to be able to support her foot a little bit of dorsiflexion to put a stretch on the tendon. Since this is a sheathed tendon, we want the tendon on this light stretch so that we can envision rolling the sheath against the firm surface of the tendon that it surrounds. Since the Achilles has a paratendon around it, we treat it as a sheathed tendon, and we want the tendon to be taut so that we have a firm surface to rub the sheath around. You can use flats of fingers or the flats of thumbs to find the most tender spot on the tendon, and then start slowly to apply a rolling motion on the tendon. To rub the sheath against the surface of the tendon body. And notice I'm not flexing my thumb joints, I'm moving my whole thumb as I do this friction work. The first application of friction is about 30 seconds to a minute. Moderate enough pressure so that the client feels some discomfort, but not super painful. So if we are working on a pain scale from 0 to 10, we'd be working at about a 7 level. After a minute of friction, we're going to stop. When treating for Achilles tendonitis, it's really important to treat as much of the tendon as possible, including the anterior surface. So after doing friction on the sides of the tendon, we want to have the client with the foot fully plantar flexed and relaxed so that the tendon is now slack, because this is the only way we can get to the anterior surface. I'm going to hold the foot, use my right thumb to push the tendon from lateral to medial. And then I take my other hand and put the flat of my index finger against the tendon, trying to think about getting at the front of the tendon at the anterior surface. I could use a braced finger, and now all I'm doing is rolling the front of the tendon. Sammy, how does that feel?
It's not painful, but
a little uncomfortable. Okay, so that's a good level. And we also want to be able to get to the lateral side of the tendon. So just for the purposes of the video, I'm going to move to this foot. Again, we're slack into the tendon. I'm going to press the tendon from medial to lateral to be able to get access to as much of the lateral aspect of the anterior surface as possible. And again, just rolling the tendon. Make sure you're not going longitudinally, because that's the direction that Dr. Syriac says helps create the injury. We don't really know if that's the case. However, based on my experience, I'm just going to continue to do this cross fiber friction on the anterior surface. At the end of the treatment with deep transverse friction for Achilles tendinopathy, we can do some isolytic contractions. Isolytic contractions are resisted eccentric contractions that help to reset the muscle and get it to re-engage more fully. Oftentimes during an injury, the muscle becomes inhibited, and this is just a way to let the brain know that it's time to have it start working a little more efficiently. So we start with the muscle tissue shortened, and then the client resists slightly while we take her through a motion from the shortened position to the lengthened position. So in the case of the Achilles, we're working with the calf muscles. So that would be, she starts in plantar flexion with the calf muscles shortened. I'm going to stabilize her here and then slowly push her into dorsiflexion while she resists a bit. Give me a little bit of resistance, Sammy. Not quite that much. And what we're looking for is a nice even engagement of the muscle all the way through its range. And come back up. And then a second round, you're going to give me a little bit more resistance than the first time. This should be pain-free all out throughout the process. And we're just going to, she's resisting nicely, feels nice and smooth, and she's going all the way through range of motion. This isolytic contraction focuses on the gastrocnemius because the knee is straight. We can do a more focused isolytic contraction for the soleus with the knee bent. Because the gastroc crosses the knee, bending the knee favors the soleus, which does not cross the knee joint. So again, we're going to have Sammy start with the soleus fully contracted, and then slowly pull her with a little bit of resistance on her part into dorsiflexion. We're looking for nice, smooth action, not choppy, not stop and start and come back up. The second round of isolytic contraction is a little bit more effort on the part of the client, so she's resisting a little bit harder. We are trying to re-engage the soleus muscle to act more efficiently as the injury heals in her Achilles. So we could do 2 or 3 rounds of that just for the soleus muscle. I am going to demonstrate the whole sequence for treatment for Achilles tendinopathy. Even though our focus of treatment will be on the Achilles itself, we want to do a general massage for the rest of the posterior leg in order to prepare the tissues for all of this more specific work that we're going to do. So Sammy, bring your leg out here a little bit like this. So we're going to add some, we've already put lubrication on the skin. We're doing compressive effleurage. I'm doing a shortened version of this just for the purposes of the video. I would normally spend whatever amount of time I would normally spend just working on the leg in general. Here is compressive petrissage. You may be wondering why we would do work up here on the thigh, even if we're focused on treating the Achilles tendon. But as we know, the body is fully connected. So we're just trying to work on this whole kinetic chain, because issues in the Achilles often come from issues farther upstream, either in the calf or the hamstring or the gluteal muscles. So broad cross fiber work on the hamstrings, a little stripping work. And again, I'm going a little faster than normal just because we're trying to make the best use of our time. Compressive petrissage on the calf. Trying to reduce the tension on the Achilles tendon by reducing the tension in the muscles that make up the Achilles tendon, the gastrocnemius and the soleus. So some stripping. And then we're going to move to the actual deep transverse friction work on the tendon. After the compressive effleurage, petrissage, stripping, we'll do a little pin and stretch. So, Sammy, I'm going to have you bring your foot all the way this way. And now I'm going to just find that area. Mostly, it's usually on the lateral aspect of the calf where we want to do a little pin and stretch work. So, supported thumbs, and now you're going to slowly bring your foot in the opposite direction as if you're bringing your toes to your knee. Good. And relax. And again, come back up. We'll pin a new location. And again, this pin and stretch should be pain-free, although it may be slightly uncomfortable for the client as she draws the muscle belly under the pressure from the pin, and relax. So we would possibly do that throughout the calf muscle group, depending on what we have found in our previous assessments. For doing deep transverse friction on the Achilles tendon, because it's a sheathed tendon, we want it on a light stretch to provide a firm surface to roll the sheath around the body of the tendon. And we're always looking for the most tender spot, which we've identified through our palpatory exam. And then we're going to add some friction against the tendon by rolling the tendon, or theoretically rolling the sheath around the body of the tendon, either with flats of thumbs. And notice I'm not doing flexion at the joint. I'm moving the whole thumb by moving the hand. Or we can do flats of fingers. We find the most tender spot, and we do about a minute of friction here. As treatment progresses, we're going to do longer bouts of transverse friction. But in the initial treatment, this is how we do it. And relax, and then we also want to be able to treat the anterior surface of the tendon. So Sammy, can you slide forward so you're all on the table? And we'll push the tendon from the lateral side to medially so that we can get at the anterior aspect. And then we're just doing friction by rolling the pads of the fingers against the tendon. So not going along the length of the tendon, but across the grain of the tendon. And for purposes of demonstration for the camera, we move to this foot because we need to treat the anterior aspect on the lateral side as well. So we have the foot slack so the tendon is nice and loose and able to move. We press from the medial side to the lateral side to expose as much as possible the anterior surface of the tendon. And we friction there. Now, if this is not tender, you don't need to add friction here. But we need to be able to get in to feel it to determine if it needs to be treated with deep transverse friction work. Okay, and then slide back down toward me. Finally, we're going to end with some isolytic contractions to try and re-engage the calf muscles. So a little bit farther down, Sammy, just like that. So isolytic contractions are eccentric contractions. The practitioner provides the effort while the client provides the resistance. So you're going to fully plantar flex, and then I'm going to push your foot into dorsiflexion. I want you to give me some mild resistance. So make me work for it a little bit. Not quite so hard. Just like that, all the way. Hold it just like that all the way through. This should be pain-free for the client. If it's not pain-free, she's not ready for this yet. Do that again. So nice and easy. We're looking for a nice, easy, smooth motion, not choppy. And she's good at that. And relax. So we would do a couple rounds of that, increasing the effort a little bit each time. And again, it should be pain-free throughout. And the isolytic contraction would be the last piece of the treatment for Achilles tendinopathy in this session.